Hi everyone, my name is Chalvin Sung and I'm a glaucoma specialist. Today, I'm very excited to share with you my experience with the YC-200 S+. These are my financial disclosures. Glaucoma is a life-changing diagnosis. It is a chronic disease which requires lifelong monitoring and treatment. The aim of glaucoma treatment is to preserve the vision-related quality of life. Lowering of intraocular pressure is the only proven and effective treatment and is the mainstay of glaucoma therapy. Let's begin with an overview of glaucoma treatment. To lower IOP, there are generally three options: medications, laser, and surgery. Medications are conventionally the first-line treatment for newly diagnosed glaucoma patients. While topical medications are effective, there are several pitfalls associated with the use of glaucoma eye drops. Reported patients' adherence rates are poor, especially if several eye drops are required. Eye drops are also expensive, especially the branded eye drops and the preservative-free eye drops, and the costs are cumulative. Patients often dislike using glaucoma eye drops because of the local and systemic side effects. This is a patient of mine who had a cicatricial ectropion, which resolved after stopping eye drops for a couple of months. Elderly patients often struggle to use eye drops, especially those with arthritis. And long-term use of glaucoma eye drops predispose to failure of conjunctival filtration surgery. On the other end of the spectrum, glaucoma surgery has attracted a lot of attention of late due to the emergence of MIGS. Conventional glaucoma surgery, such as trabeculectomy and tube implant surgery, are effective in lowering the IOP, but are associated with potentially sight-threatening complications, hence are usually reserved for patients with advanced glaucoma. MIGS has addressed an unmet need for a safe and effective option for patients with mild to moderate glaucoma, especially as a phacoplast procedure. However, standalone trabecular bypass MIGS still hasn't replaced medications in medically controlled mild to moderate glaucoma, as most patients would rather persist with the medications even with their side effects, rather than undergo surgery. So what is the role of laser trabeculoplasty in all this? Laser trabeculoplasty was first described in 1972 by Kresnov, who used a ruby laser on the trabecular meshwork to treat glaucoma. Other laser trabeculoplasty was initially the vogue, but this has been largely replaced by selective laser trabeculoplasty, or SLT. Histological studies have shown that SLT causes less coagulative damage and scarring to the trabecular meshwork than ALT. The mechanism of action of SLT is predominantly through its biochemical and cellular effects by recruiting matrix metalloproteinases and macrophages without the damaging mechanical effects seen in ALT. It increases aqueous outflow through the conventional outflow pathway, hence reducing IOP. How is SLT performed? SLT uses a 532 nanometer Q-switched frequency doubled ND-YAG laser with a 400 micrometer spot size and 3 nanoseconds duration. There are various lenses that you can use, and I tend to favor the Vogue Rapid SLT gonioscopy lens because there are 4 mirrors, so you wouldn't need to rotate the lens much to get access to 360 degrees of the trabecular meshwork. I helped to recruit for the light study when I was working at Moorfields Eye Hospital, so I used the same laser settings as the light study in my clinical practice. I usually perform 360 degrees of SLT with 100 non-overlapping shots. I pre-treat the eye with brimonidine at least 15 minutes before the laser. This video shows SLT performed with the 9-deck YC-200 S-Class, which I have in my clinic. You can see that the view with the laser machine is very good as it has a high-quality optical system with LED illumination. The aiming beam is also precise with a sharp edge, so it is easy to focus. The spot size of the SLT is actually quite large at 400 micrometers, so you have to be precise to aim it over the trabecular meshwork and avoid either lasering the iris or the cornea, which can increase the risk of inflammation after laser or corneal complications. I usually start with about 0.8 millijoules for non-pigmented trabecular meshwork, but for pigmented trabecular meshwork, this will require lower energy, and I start the treatment at 0.4 millijoules. The desired endpoint is the production of champagne bubbles, and you shouldn't see larger gash bubbles or blanching of the trabecular meshwork. If these are seen, then titrate the power downwards in 0.1 millijoule steps. To help you to keep track of which area of the eye you have lasered, the machine helps to count the SLT shots and shows you the area you should be treating. So you can use this as a guide to ensure that all parts of the angle are well lasered. I will measure the IOP about 1 hour after the SLT procedure to ensure that there is no IOP spike. It is a bit controversial whether to prescribe topical steroids and NSAIDs after SLT, and there is a randomized controlled study which showed that topical steroids or NSAIDs may improve the IOP lowering effect of SLT. There are others who think that the inflammation associated with SLT is important to lower the IOP, hence discourage the use of NSAIDs or steroids after laser. In the light study, patients are actually just given 1 bottle of topical NSAIDs to stand by, to be used only if the patient has significant discomfort despite oral analgesia. Personally, I haven't found that steroids or NSAIDs after SLT make a significant difference in the IOP lowering effects. After SLT, I usually review the patient at 6 weeks to determine the efficacy of SLT, though you may also consider an additional review at 2 weeks to determine whether there are any complications from SLT.